Thank you, Professor Moussaoui. Thank you for giving me the opportunity to listen to these two amazing presentations. So thank you. I have a few words of conflict of interest. First, I am professor in statistics. This is not sexy. I am sorry, but that's life. For this reason, I give a lot of advice for pharmaceutical firms, mainly outside psychiatry, but so this is in line with my presentation. I am very used to the evaluation of medication. I am a child and adolescent psychiatrist. This is also my job. This is much more funny. And I am fond of psychoanalysis. That's life. This is no more in fashion, but it helps me a lot in my practice, and so I like it. And so it may consist in a conflict of interest. So, to begin with the core of the problem, we have seen that non-pharmacological treatments are crucial in psychiatry. And this is even more true in child and adolescent psychiatry, where you know that medication are a little bit less effective than adult psychiatry for many reasons. Nowadays, we have to use evidence-based treatment. Everybody agrees with that, even psychoanalysts, so no problem. Why? Because there are ethical reasons for that. When we face patients and family, we have to give them things that have been evaluated with science. This is ethical. And the other thing is that it is economical. We have not a lot of money to treat patients, and so we have to invest in treatment which works. And so evidence-based is now a basis. When you listen to, but what is evidence-based medicine? You know that there are levels of evidence, supposedly. At the highest level you had review and meta-analysis. I say you had because many people consider nowadays that evidence-based meta-analysis are not so correct and reliable. But just after you have randomized controlled trial, and after you have epidemiology, case studies, etc., etc. This is what people consider. Okay. But randomized controlled trials are very expensive. You know, the cost of a randomized controlled trial to assess the efficacy of a new oral anticoagulant agent in atrial fibrillation is 200 million euros. 200 million euros. One trial, one drug, one indication. And in addition, it costs, but it needs a huge amount of work. You know, this is so difficult to do a randomized controlled trial that I say to my students, you will do it only one time in your life. After, forget it. And when you have non-pharmacological intervention, you have methodological issues. What is the placebo of non-pharmacological intervention? What is the effect of the psychologist, of the psychotherapist? And so, because we have no money to evaluate non-pharmacological treatment, because it is much more difficult than to evaluate medication, we are trapped. And this is even more true in child and adolescent psychiatry, where we have to evaluate treatment between 0 to 3 years, 3 years to 6, 6 to 10, 10 to 18. Imagine in adult psychiatry, you are from 20 to 18. So, no, in fact, this is not true. And we have to come back to the very basis of the evaluation of medication. From where do we come? And we will see that I will follow you in what you said. First point, the success of occidental medicine, and in every country nowadays, when you have a myocardial infarction, people use occidental medicine. Even in Beijing, in China. You have a Chinese medicine, I know that. But you use stent even in Beijing. So you have now occidental medicine that is everywhere, and the success of occidental medicine has been obtained at the cost of a marginalization of mind and at the cost of a physiological authoritarianism. And I don't say this is bad. I just say this is reality. In the past, we had global medicine with culture, mind, body, organs. Everything was, it was a global medicine, a comprehensive medicine, 3,000 years ago, everywhere on the planet. And it didn't work that well. You know, it is better to be treated for myocardial infarction nowadays than 3,000 years ago. We have to acknowledge that. And so we had a global medicine, and people noticed that it was not so brilliant. And so progressively they studied anatomy, microscopes, physiology, and at the end of 18th century, they said, well, we have organs, and when you are sick, it is because you have a failure of an organ. And if you treat the organ, you will be cured. And it works many times, you know, especially with microbes. You have a pneumonia, this is because you have a microbe. If you kill the microbe, you cure the patient. And it worked. You know that 200 years ago, in my country, half of kids did not exceed 3 years old because of microbes. And so, thanks to biology, this is no more the case. But because of this huge success, we have lost the holistically incorporated medicine. We have nowadays cardiologists, pneumologists, nephrologists all over the planet, and you have psychiatrists for what? For the mind. But what is it? Second part, we all know that physiology is only a part of the equation. During the 19th century, people considered that with biology we had the graal, the ultimate graal of evaluation of efficacy. We had, this is what said Claude Bernard, one father of physiopathology. He said, if there is a disease, there is a failure of an organ. If you find which treatment can act on this failure, you will show that the treatment is efficient. There was a biological determinism between patient, disease, and treatment. No statistics, only mechanism of action. And this is up to the half of the 20th century, where people say, well, this does not work always. When people have a lung cancer, what is the cause of lung cancer? Most often cigarettes. Once you know that, this does not help you to cure patients, you know. When people have lung cancer, they can continue to smoke. This is no more the problem. The problem is surgery, radiotherapy, and chemotherapy. This is no more the cigarette. And so, after the Second World War, the people said, well, biology is not enough. We have to use another paradigm, and they use statistics. And in particular, they used randomization. And it worked quite well. And because of this reason, nowadays we use randomized controlled trial. And if a pharmaceutic firm wants to have its drug approved by the FDA or the EMA, the firm has to do randomized controlled trial. This is mandatory. Many people consider that randomized controlled trials are theoretically neutral because statistics are figures and figures are neutral. This is not true. And this is not true because all physicians rely on biology. We in all countries on the world, when you study medicine, most of the time you study biology. And this is not necessarily a problem, but there is an implication of that. Biology is a dominant ideology in the area of medicine. And so if we want to show that a treatment is efficient, or then we need some kind of biological argument. There is always the necessity to find a biological argument. There was a meta-analysis of homeopathy in chronic asthma. It was published in the Lancet in the 90s. And the meta-analysis was positive. And of course, nobody believed to the meta-analysis, because everybody knows that homeopathy does not work because there is nothing in the pill. There is nothing in the pill. It does not work on biological grounds. This is a principle. And even if statistics say we have a p-value of 1%, no. It does not work. So you see, the evaluation of medication still rely a lot on biology, even if we use statistics. And this is the reason why people use placebo. This is crazy in a way. Nobody uses placebo in their day-to-day clinical practice. So this is very rare. So why do we compare medication to placebo if placebo is not a clinically relevant comparator? This is crazy. And the answer is because we want to show that the medication has an intrinsic effect related to the biology of the organism. And of course, you see where I want to go. If you evaluate psychotherapies, this is meaningless to compare to a placebo. This does not make sense. Because psychotherapies, by definition, shouldn't rely only on a biological ideology. By definition, because this is a psychological treatment. This is not a biological treatment. I know that neuroscience tries to make a bind. I know that. Don't be afraid. So, even when you use randomized controlled trial, you still stick to the biological ideology. Another point, if you want to understand why people use randomized controlled trial, many people say this is because when you use a randomized controlled trial, you have a benefit-risk ratio, and this is why medication have a market authorization. And in fact, this is not true. Do you know in the FDA or in the EMA how they decide that there is a positive benefit-risk ratio? They vote. They vote. Because they see the benefit with the primary outcome, the risk, side effects in randomized controlled trial are not that well assessed, but the balance between both, this is not scientific, and they have to vote the risk-benefit ratio. No, the real interest of randomized controlled trial, which is a big, very important interest, this is the protection against pseudoscience and irrationality. If you have a positive randomized controlled trial, you have shown that the drug does something. And you know that for centuries, medicine and patients have suffered from quackery, from drugs that did nothing and from drugs that were even harmful. And randomized controlled trial are an excellent strategy against that. So randomized controlled trials are very interesting, but they are only a partial success. What is the real interest of randomized controlled trial? They are the most efficient design in providing a convincing answer. They are interesting because they convince people. And convincing to answer to a simple question. If you consider you have a backache and you ask yourself, do I have to sleep on a hard bed or the soft bed? You know that 20 years ago people said if you have backache you should sleep on a hard bed. They did a randomized controlled trial and this is not true. This is not true. And once the randomized controlled trial has been published, from that time, all rheumatologists accepted to say, no hard bed, you can do what you want. This is not the problem. The problem is to move and to return to your job. So randomized controlled trials are very convincing because the design is very simple, and when you have a simple question, hard bed, soft bed, you can do a randomized controlled trial, you will do the job. After, there are some fantasies about randomized controlled trial. The first one is that it is supposed that randomized controlled trial proves that there is a causal relationship between treatments and efficacy, and this is not true. Just realize that for 3,000 years, philosophers don't know what is causality. You have 10 to 20 definitions of causality, so why statisticians would have found the real and definite definition of causality? This is crazy. We could discuss about that in the discussion. More important, randomized controlled trial do not answer to the question, how do patients feel once undergoing treatment? I know that there are quality of life scale, but this is quality of life scale do not answer to the question, how do you feel when you take a treatment? When you use an antidepressant drug, what does it make to you as a thinking subject? And of course, this is even more important for psychological treatment. When you do a psychodynamic treatment, when you do IPT, after, how do you feel yourself? If you do not tackle this question in a randomized controlled trial, you do only half of the job. So, 2 slides of conclusion. First, very important, we forget it all the time, medicine has suffered for centuries from quackery. And so we have to use science against quackery. But nowadays, we do not progress, and we do not progress because there is some kind of methodological colonialism. Colonialism from biology, colonialism from statistics and quantitative approach. And we could discuss that a randomized controlled trial gives some statistical evidence, but statistical evidence is about an average subject, and an average subject, you will never meet an average subject in your practice. So there is some kind of sophism in what is statistical evidence. I don't think it is meaningless. I think this is much more complex than people say. When you do a randomized controlled trial, this is very difficult to tackle the question of patient-physician relationship. And you know that in psychotherapies, therapist-patient interaction is at the basis of the treatment. And so, we have not to accept that. And so what are the suggestions? This is my last slide. How should we do in practice? First, and we do not do that enough, when you design a new psychological treatment, you have to describe it very precisely so that patients can know what they will face. Second point, like medication, you should discuss about mechanism of action. There are mechanisms of action with psychological treatment. In psychoanalysis, you have thousands of pages about that. With CBT, you have also thousands of pages. Mechanisms of action are very important. Statistics are not the only way to prove evidence. Then you have to use qualitative study, because qualitative studies are not expensive and they answer to very important questions. What is the patient experience? What is the treatment? And people evaluating medication should do also qualitative study, even for treatment in cancer. Then, if you want to answer to the very simple question, is my psychological treatment better than a given alternative? If you want to be very convincing, and sometimes you need to be convincing to have money, to have your treatment reimbursed, then you have to do a randomized controlled trial. Okay? But this is only a part of the answer. And nowadays, you have more and more some interest on big epidemiological studies, big register, sometimes coming from health insurance database, that can evaluate psychological treatment in real life, and that can find to which treatment, to which patient, which therapist, which therapy is the most appropriate. And of course, this is very interesting on a practical point of view. So, to come back to my first slide, should we evaluate psychotherapies like we evaluate medication? Yes and no. Yes, in part. But I would say more that the evaluation of medication should learn a lot from the evaluation of psychological treatment. Thank you for your attention.